Hello everyone. Today I'll be taking another VivaLive session with QQSphere on the subject pharmacology with the topic cardiovascular pharmacology, and the subtopic will be beta blockers. Let's start.
Welcome to the examination. We will begin with a focus on beta blockers. To start, can you discuss the mechanism of action of beta blockers, specifically how they affect the cardiovascular system?
The beta blockers are used as cardiovascular management agents. They act by blocking adrenaline, reducing heart rate and blood pressure.
That's correct. They block beta adrenergic receptors. Now, can you name a few clinical conditions where beta blockers are commonly prescribed?
Uh, they are prescribed in the case of hypertension, angina, arrhythmias, heart failure, and these cardiovascular conditions.
Yes, those are the main indications. Continuing with our discussion, let's consider the differences within the drug class.
There are three subclasses. Selective, that is cardioselective, beta 1 selective. They target beta 1 receptors in the heart. Non selective are beta 1 and beta 2 acting. They target beta 1 receptors in heart and beta 2 receptors in lungs and blood vessels. And there are mixed kind which act on beta 1, beta 2, and alpha 1. And they induce vasodilation.
Excellent breakdown. Given those distinctions, why might a cardioselective beta blocker be preferred in a patient with asthma or COPD?
They are preferred in patients with asthma or COPD due to lower pulmonary impact.
Exactly. They minimize the risk of bronchoconstriction. Now, what are some common side effects associated with beta blockers?
The side effects are fatigue, lethargy, cold extremities, insomnia and vivid dreams, and erectile dysfunction.
Those are indeed some common ones. We should also consider potential adverse effects in patients with certain pre-existing conditions. In which cardiovascular condition would beta blockers be generally contraindicated?
They are contraindicated in case of asthma, severe bradycardia, and high degree heart block.
That's absolute correct. They can worsen those conditions and are generally avoided. What about drug-drug interactions? Can you think of a drug that combined with a beta blocker could cause severe bradycardia or heart block?
No, can you please explain?
Certainly. Combining beta blockers with calcium channel blockers, especially non-dihydropyridines like verapamil or diltiazem, can significantly slow heart rate and reduce contractility, increasing the risk of serious bradycardia. Another combination would be with amiodarone, an antiarrhythmic. Does that make sense?
Yes, thank you.
You're welcome. Now, let's consider a scenario. If a patient presents with symptoms like wheezing and shortness of breath after starting a new beta blocker, what do you think is occurring and what would be your immediate action?
In that case, the patient has had a non-selective beta blocker, and it is causing bronchoconstriction.
That's correct. And what would be the immediate action you would take?
Prescribe a cardioselective beta blocker.
That would be a long-term consideration. But first, you would need to stop the current beta blocker and manage the acute bronchospasm, perhaps with bronchodilators. Finally, can you tell me what happens to blood glucose levels with beta blockers, especially in diabetic patients?